Hello everyone. Today we are going to discuss tetralogy of Fallot and what an anesthesiologist needs to know about it. Four anatomical components. The first one is a large VSD, ventricular septal defect, overriding of the aorta, which means that the aorta is situated on the VSD and not completely on the left ventricle. The third component is the right ventricular outflow tract obstruction. And the fourth component is the right ventricular hypertrophy. The main determinant of the severity of symptoms and cyanosis is the degree of RVOT obstruction. The more the degree of obstruction, the more the cyanosis and the presence of hypercyanotic spells. Some children may have minimal right ventricular outflow obstruction, and they are called pink Fallot. There are four major variants of tetralogy of Fallot. The first one is tetralogy of Fallot with pulmonary stenosis, which may be subvalvular, valvular, or supravalvular. This is the most common variant. The second variant is the tetralogy of Fallot with pulmonary atresia, which is commonly associated with hypoplastic pulmonary arteries with or without collaterals between the aorta and the pulmonary arteries. These collaterals are called MACs. The third variant is tetralogy of Fallot with absent pulmonary valve. The fourth variant is tetralogy of Fallot with atrioventricular septal defect, which is the least common variant. Another abnormality can be seen with Fallot is the abnormal coronary anatomy, which is seen in 10% of cases, which means that the right coronary artery is crossing the RVOT. Some infants may have dynamic obstruction at the pulmonary infundibulum. These infants, while crying, will have an increase in infundibular contractility and increased subpulmonic stenosis, causing more deoxygenated blood to shunt from the right ventricle to the left ventricle across the VSD. So the child becomes deeply cyanosed, which is called hypercyanotic or TET spells. Management of spells include oxygen with high FiO2, which leads to pulmonary vasodilation, causing a decrease in the pulmonary vascular resistance, sedation using morphine or ketamine, volume administration to help opening the right ventricular outflow tract by 20 ml per kg, knee to chest position, which is a squatting position, which increases the systemic vascular resistance and reduces right to left shunt. Beta blockers are given to these patients to decrease the infundibular spasm. The aims of anesthesia for surgery for tetralogy of Fallot are four components. First one is to maintain or increase the systemic vascular resistance, even by inotropes. Second one is to reduce the pulmonary vascular resistance. Merinone is the most commonly used, and avoid hypercyanotic episodes, TET spells, and avoidance of metabolic disturbances like acidosis, hypothermia, hypercapnia, and sympathetic stimulation causing the tachycardia. Surgical management of Fallot can be either palliative or corrective. Palliative surgery is called modified VT shunt, which is indicated in infants with duct-dependent pulmonary circulation, such as TOF with pulmonary atresia, or very small pulmonary arteries, and in Fallot with anomalous coronary artery. Now, VT shunt is a Gore-Tex graft between the subclavian artery and the right or left pulmonary artery. Corrective surgery is the total repair of Fallot and will be discussed in another slide. The preoperative evaluation of Fallot patient includes history for the frequency of spells, complications of long-standing cyanosis such as stroke and intracerebral abscess. Examination includes central cyanosis by looking at the tongue, clubbing, presence of long harsh ejection systolic murmur at the pulmonary area due to turbulent flow at the RVOT. Investigations include a preoperative oxygen saturation, which is most commonly between 65 to 85%. CBC will show polycythemia due to cyanosis which can cause reduced platelet count and coagulation disorders. Chest X-ray will show the classic boot-shaped heart due to the right ventricular hypertrophy. Echo to determine the degree and size of right ventricular outflow tract obstruction. The key points in management of anesthesia in PT shunt are as follows. If the infant is duct dependent, so maintain intraoperative prostaglandin infusion. Avoid and treat the hypercyanotic spells. The surgeon will clamp the subclavian artery, so the radial artery cannulation of this side should be avoided. Clamping of the pulmonary artery may cause transient increase in hypoxia. A low dose heparin to maintain the flow inside the shunt. Inotropic support may be needed, usually adrenaline infusion, and periodic arterial blood gases to correct metabolic acidosis. Also, before opening of the shunt, decrease the pulmonary vascular resistance by increasing the FI2 before opening of the shunt. Hyperventilation and correction of acidosis. After shunt opening, reduce the FI2 to 30% on room air. The ideal saturation should be between 80 to 85% on room air and systolic blood pressure more than 80 mm mercury. If saturation is less than 70%, shunt may be too small and should be reoperated. If saturation is 100% and the mean arterial blood pressure is decreased, so the shunt may be too big and may cause congestion. Other types of shunt include Bott shunt, which connects the descending aorta to the pulmonary arteries, and Watterson shunt, which connects the ascending aorta to the main or right pulmonary artery. Classic BT shunt, which connects the right or left subclavian directly to the right or left pulmonary artery, respectively. Corrective surgery for Fallot consists of closure of the VSD using a pericardial patch via transatrial approach, relief of the right ventricular outflow tract obstruction, which includes the following approaches according to the level of obstruction: either resection of the muscle bundles in pulmonary infundibulum or right ventricular outflow tract patch or transannular patch or pulmonary valvotomy. After the repair, check for the residual VSD and degree of residual RVOT obstruction using transesophageal echo and direct measurement of the pressure across the RVOT. Ideally, right ventricular pressure should be less than 2/3 of the systemic pressure. In addition to the preoperative evaluation previously discussed, avoid prolonged fasting. Pre-medication should be used. The child should be calm during induction of anesthesia. Infective endocarditis prophylaxis. Continue propranolol up to the day of surgery. The main goals of induction of anesthesia in repair of Fallot are to decrease the pulmonary vascular resistance and maintain the systemic vascular resistance. Also avoid tachycardia and infundibular spasm. Ketamine is an IV induction agent of choice as it increases systemic vascular resistance. Management of hypercyanotic spells, as previously discussed under anesthesia by high FiO2, fluid administration, deepening of the anesthesia by fentanyl, and propranolol to decrease the infundibular spasm. Right ventricular hypertrophy will cause a high filling pressure, which means that more fluids may be needed. After the repair, a gradient across the pulmonary valve of less than 40 mm mercury is accepted. Weaning from cardiopulmonary bypass by inotropic support in the form of merinone, which is a phosphodiesterase inhibitor that decreases the pulmonary vascular resistance, adrenaline or noradrenaline to increase systemic vascular resistance and increase contractility. Pacing may be needed. Maintain normal serum potassium and normothermia. Use of tranexamic acid and platelet transfusion if there is a coagulation disorder. One of the most common complications after repair of Fallot is junctional ectopic tachycardia, which is frequently seen following the repair. Management includes cooling, sedation, magnesium sulfate, and in resistant cases, amiodarone infusion can be used. Thank you.